Good afternoon, this is Dave. I was unable to attend the tutorial today, but I've stood on this presentation about deprescribing antihypertensives in the elderly. So the first question is, in which patients should we consider stopping antihypertensive therapy? So patients who are considered frail, which means they can't walk more than 6 meters in 8 seconds. In those patients, there's no association between blood pressure and mortality. That also extends to patients who are unable to walk at all. Patients who are high falls risk are another group to consider, as antihypertensive therapy is associated with increased risk of falls, which obviously have rather poor outcomes. And postural hypotension as well, which is defined as a drop of more than 20 millimeters mercury systolic or 10 diastolic on standing, and obviously that's related to falls risk as well. And there were some recommendations on how to deprescribe safely. So if a patient's on more than one antihypertensive, stick to one at a time. And of course, depending on the dose, this may not always work, but the recommendation is to reduce the dose by 25% per month with the aim of ceasing altogether after 3 or 4 months. Also keeping in mind that in complex patients, an antihypertensive may be doing more than just treating blood pressure. So a patient who has got a cardiac history might also, say, have angina, heart failure, and the beta blocker may be helping those, and therefore stopping it may make that situation worse. So that's just something to be mindful of. There was some conflicting data regarding the link between low blood pressure and mortality in the elderly people. Different studies found different things, but what the document has is that a diastolic of between 70 and 90 and a systolic of between 120 and 140 are ideal in terms of risk. So below that may be associated with worse outcomes, and above definitely is. Having said that, although there's some good evidence to say that antihypertensive in general is helpful in elderly patients, treating them more aggressively doesn't actually seem to improve blood pressure control very much, and the small differences in blood pressure that one can attain, which are often less than 10 millimeters mercury, don't seem to make a significant difference to outcomes. Another thing to keep in mind is that as somebody gets older, their relative risk reduction when treated with antihypertensives may decrease, whilst the absolute risk of having an event may increase. The benefits still exist in elderly patients, but also the adverse effects remain. Having said that, the risk of death from other causes also goes up with age, so the association between blood pressure and mortality declines with age as a result of that. So to look into a bit more detail, I had a look at this Cochrane review regarding hypertension in the elderly. The reference is on the left there. So looking at a few specific benefits of antihypertensives, there was some low quality evidence that there might be a small reduction in overall mortality in people over 60 with antihypertensives. Now, the number needed to treat for these and really the level of certainty weren't great. However, in the high risk patients, so those with, say, a systolic of over 160, the benefits were much more obvious. If we look at the total mortality of patients over 80, antihypertensive therapy had no impact on the risk of mortality at all. If we look just at cardiovascular mortality rather than overall and combine that with data on morbidity, the numbers look a lot nicer. There's a definite benefit to antihypertensive therapy, regardless of how much the blood pressure actually improves. And again, the effect is more pronounced in the high-risk patients, but that's definitely worthwhile considering the cost and disability and death associated with cardiovascular events. In patients over 80, looking at cardiovascular mortality, the numbers needed to treat are higher, so the benefit of antihypertensive therapy isn't quite so great as it is in people between 60 and 80, although the benefit is still there. Having said that, there is not a significant reduction in deaths and disability from coronary heart disease in people over 80 from antihypertensive therapy, which I thought was interesting. Looking at the data in more detail, it's really cerebrovascular disease where the big difference is made in people who are over 80. Now, if we have had a look at some other separate graphs, which I won't go into now, there isn't a significant reduction in deaths from cerebrovascular disease with antihypertensive treatment, but there is quite a large difference in the level of morbidity. So when we combine that data together, we've got a number needed to treat of 27, which is quite good. And if we were talking about just the level of disability, which is a significant cause of cost in the health system, as well as problems for patients, increased aged care, etc., it's really quite worthwhile for that purpose. In summary, I shall reiterate that as people get older, the benefits of antihypertensive therapy overall decline and people get more susceptible to adverse effects, the most dangerous of those being falls, particularly in people who are high falls risk or have postural hypotension already, but therapy can still be worthwhile in well older people, even people over 85. Apart from that, aggressive antihypertensive therapy doesn't really seem to improve control that much and doesn't seem to change outcomes in the literature we have available. And withdrawing these agents too quickly can cause problems like peripheral edema, tachycardia, rebound hypertension, can worsen heart failure if present. So just like we start low and go slow with older people, it's a similar situation in reverse. So thank you for listening to this presentation.